This is Sg2 Perspectives, a conversation with Sg2 experts and industry thought leaders about the biggest trends in healthcare and what we expect that's going to mean for the future of healthcare delivery.
It's the older, sicker, more comorbid, higher acuity patient population that is challenging organizations everywhere they look. We consider this a very demand-driven service line, largely due to that plus 65 population. And over the next 10 years, it's going to get even more acute.
Welcome to Sg2 Perspectives. My name is Jayme Zage, and I'm excited to share with you perspectives from our service line leaders as they relate to some of the biggest disruptions and differentiators impacting clinical growth service lines. Joining me today are Chad Giese to talk about cardiovascular, Dionne Dela Cruz to cover women's, Rachael Zirkelbach to cover surgery, and Setu Shah, who partners with Kara Marlatt to cover cancer. Kara is going to be our guest host for this episode. I hope you really enjoy this discussion. Kara, it's all yours.
Thank you, Jayme. Thank you all for joining me today. I'm really happy to have you all. And Chad, thank you for being our resident cardiovascular expert. You have extensive experience in the cardiovascular space. I'd like to get us started out by asking all about some of the major influencers that are causing each service lines that you cover to think differently, to innovate from within, or structuring them a little bit differently compared to normal. Chad, I'd actually like to start off with you and see what's happening in the cardiovascular space.
Sure. Thanks for letting me join this such a strong group of subject matter experts. I'm so excited to get to join the team today. When we think about the major drivers of cardiovascular utilization, it is a demand-driven service line. There is demand everywhere we look across the system of care, from the clinics to the offices to the diagnostic imaging centers to the ED to the hospital itself. And it's largely driven by the aging of the population. This is not a new trend that we've been tracking. Since I joined Sg2 almost 13 years ago, we have been noticing the impact of that baby boomer generation on utilization. It's the older, sicker, more comorbid, higher acuity patient population that is challenging organizations everywhere they look. We consider this a demand-driven service line, largely due to that plus 65 population. And over the next 10 years, it's going to get even more acute. If we look at just the hospital inpatient demand, 65% of all discharges today are in the plus 65 patients. That is going to increase to 72% of all inpatient discharges by 2035. This is a big challenge that organizations are having to deal with. It's going to require creativity, attention to detail, team-based care, and leveraging all assets across the care continuum in all resources in novel ways to manage that. Setu, you've got multiple populations at play within the cancer space.
Yeah, Chad. In cancer, we like to one-up the CV service line. We have an aging population, which in cancer, incidence and prevalence significantly increases with age. And as the population ages, we can expect that influence cancer epidemiology and demographic changes. Part of this is also related to rising survivorship. We know that by 2040, there are expected to be 26 million cancer survivors, with 73% of those being 65 plus. Cancer is increasingly being thought of as this chronic condition. We're going to see long-lasting effects of therapeutics and potential for reoccurrence or even second primary cancers. 65 plus makes up the majority of our population. On the inpatient side, that's about 90% of discharges being 65 plus. You all have seen the headlines. There's this increasing diagnosis of early onset cancer being diagnosed in less than 50-year-olds. This has particularly received a lot of spotlight in colorectal cancers. And there are many other cancers we're looking at this closely. We don't unfortunately like to think about this, but in cancer, oftentimes a younger patient means different payer mix. And so commercial patients, that impacts the way we think about strategy. And sometimes younger patients engage with health systems differently. So health systems increasingly thinking about what it means for digital engagement. 94% of consumers go where they're referred. Critical to think about educating referral providers and what that referral pathways look like. As we think about all these demographic shifts and changes, health systems are considering what do we need to do differently and innovate with both our strategy and our clinical and programmatic infrastructure to capture and meet the needs of both this aging population, but also potentially growing younger population. Now, segmentation is something we think about in cancer, but it's something you think about, Dionne, in women's health as well.
It is definitely. And there are certainly some alignment with cancer and in women's health. When we talk about women's health and we talk about demand for services, it's important to take a step back and to think more broadly about that entire spectrum of life stages. Healthcare for women in her 20s is going to look completely different than what she needs in her 40s and then in her 60s. When I think about women's health strategy today, the comprehensive programs increasingly emphasize this lifespan segmentation of care. So from adolescence through midlife services and beyond to chronic care. There are a lot of different trends emerging in each of these groups. So for women in their reproductive years, we're seeing a clear decline in birth rates. We've talked about this for years, which is a limiting factor for organic growth, for obstetrics programs. On the flip side, Chad talked about the aging population. And as the population ages, we know women live longer and will make up an increasing proportion of that aging population. So over the next 10 years, we do see this growing demand for services that are tailored to midlife and 65 plus age women that are driving new demand. But overall in women's health, we're seeing a shift in demand when we segment the population like this, and health systems that want to capture this new demand are pivoting into gynecology and into other specialty services that better support women across the lifespan as they age.
When I look at outpatient volumes across those service lines, more than 50% of that patient population is over the age of 65. Those service lines are facing long-term demand pressure, and they're also up against workforce shortages, access challenges, and capacity strains at the same time that limits surgical throughput. At the same time, post-acute is facing a lot of the same pressures. We've got an aging population that drives long-term demand, while more complex patients are being discharged from hospitals that are under pressure to turn over beds more quickly. And workforce is also a challenge here. A lot of SNF operators breathe a sigh of relief with the staffing mandate pause, but then on the other side, hospital-at-home operators are in this state of limbo of what do we do with our hospital-at-home program with the expiration of the waiver. While demand is rising in surgery and post-acute, organizations are having to rethink how and where care is being delivered. And it's not just because of patient volume, it's also because of the challenges they face.
That's great. What I heard across the board is what you're telling all of our listeners, that clearly high demand exists across all service lines. And you're seeing it not only for the 65 plus group, but you're also seeing younger patients that are entering your respective service lines that you cover and needing care. And so we're having to adapt in different ways to meet patients where they're at. That brings me to my next question. Where are organizations actually making some of the advances in the service lines that you cover to improve access given this rise in demand? Setu, what do we actually see in cancer?
In cancer, there are two main areas where organizations are improving access. First is access to advanced technologies and therapeutics. In recent years, things like theranostics, cellular therapy is really coming onto the market. We're seeing great outcomes and is becoming standard of care in certain tumor types. Those who already offer the technology or therapeutic, like an AMC, they're figuring out how to scale more effectively, how to reach more patients, how to reach more markets. Those who are looking to add it and maybe historically haven't, like the community health system, they're figuring out what is the clinical, financial, and operational infrastructure needed to build something out like this, particularly onboarding a new therapeutic or technology versus referring out what they have done traditionally. That's number one. Number two is just improving the overall timely access. Timely access has always been important in cancer care, but the way it's changing more recently is speeding up that time to first contact, consult, or visit, recognizing that if you're able to capture and meet the need of that patient early on, you're able to better meet the needs of their services throughout the rest of their care journey. It's pushing organizations to think about, if I historically saw a patient in maybe 1 week or 7 days, we'd like to hold ourselves to an internal benchmark of seeing a patient within 3 to 5 days. Now, this won't happen overnight. This is often a multi-year journey. Both the innovation and consumer needs and competition is pushing organizations to think about improving the access to better meet that demand overall, and more yet, also stay competitive.
Dionne, what are you actually seeing on the women's health side?
In women's health, we have to acknowledge what's happening outside of the walls of the traditional health system. The urgency for health systems to redesign how we deliver internally is driven by a lot of external factors and innovation. So this is femtech, this is investment from private equity and venture capital, this is changes in women as healthcare consumers. We know women are power users of virtual health. We also often hear about maternal care deserts, but there's also gyne deserts as well. And I don't think it's a big secret that traditional systems haven't always been structured to meet all of women's needs in a 30-minute appointment, especially in the midlife area. That's the gap that we see femtech stepping into. One really great example of internal redesign and change that we've seen is the rise of midlife and menopause programs. So menopause is having a moment both clinically and culturally. Back in the early 2000s, there were early studies that linked hormone replacement therapy to health risks, but it didn't look at age cohorts and it cost us trust with women. There were new headlines just this month where the FDA will remove those long-standing warnings on the boxes of hormone menopause drugs. These warnings came from that study about 20 years ago. We're seeing a real resurgence driven by femtech that's heavily investing in midlife health. So these are virtual first companies like MIDI Health. And there's also just growing cultural awareness. There's social media and advocates that are helping to normalize the conversation. And we're seeing menopause care gain a lot of momentum. Health systems are recognizing that opportunity to fill a big gap for midlife services that often go beyond gynecology and into multiple specialties. So that's women's health. Rachel, I know there's always a lot happening in the surgery space.
Dionne, there is. When I have a conversation with folks about surgery, two things consistently come up. The first is looking at where procedures are taking place. Organizations are being very deliberate about shifting those low acuity procedures to ambulatory settings while preserving hospital-based ORs for those more complex or inpatient cases. The other topic that comes up frequently is the utilization of APPs. A lot of that has to do with the workforce shortage that is in urology and ophthalmology, et cetera. And I wouldn't say innovation, but as a foundational design, because we need to be using our APPs to the top of their license. For example, an organization in the Midwest has a urogynecologist who trained their physician assistant to recognize which patients were surgical candidates. Eventually, that PA was able to see nearly all new patients independently. This allowed the urogyne then to double his surgical volume, and his practice became a destination center. Another example from an interview that I listened to was from Moffitt Cancer Center, where their APPs and their GU oncology program first assist on inpatient cases. They perform outpatient procedures, and they run outpatient clinics completely independently. Your state regulations are going to matter. But what's interesting across all of these examples is how thoughtfully organizations are working APPs to the top of their license, not only to create capacity, but to create a more enjoyable work environment for APPs and physicians. Chad, I know capacity constraints can be a challenge in CV. What's going on there?
Capacity is a challenge. Every time I talk to our members or a group of providers, I ask who is struggling to open up capacity, both on the inpatient side and maybe on the clinics, and everybody is struggling. Everyone is running high average daily census. Everyone has long wait times in their clinics. Where do we start this conversation? A common thread that is through each one of the service line examples you've heard is taking a data-driven approach to identify where opportunities exist. How do you bring on new innovations? What are the impact of the innovation or the new therapeutic that you're going to be providing patients? And so I'd be remiss if I didn't think about and touch on that upstream side of things and things like as simple as guideline-directed medical therapy, that GDMT for cardiovascular patients, getting them on GLP-1s, SGLT2 inhibitors, and what is the downstream impact? One capacity solution. The other side of this is more on the procedural space. Ambulatory surgery centers, much like what Rachel talks about every day, are top of mind. Oftentimes a big challenge, requiring significant investment to shift patients from their hospital-based cath lab, EP lab, vascular lab to an ambulatory site, one that does have potential in the right market with the right organization, with the right patient population to support it, as well as physician workforce and clinician support. Those two areas, upstream GDMT management and that hospital-based high acuity procedural lab space, are two areas we talk about often within CV.
I'm hearing from you all that there's a lot of external factors that are causing us to change, from any new innovations to maybe competition, and even to really consumers pushing us to change and thinking about how we figure out how to create more access points and overcome capacity challenges to better serve our patients. Where should service lines and organizations look to next in order to remain differentiated in the market? What should the respective service lines that you cover be paying attention to? Rachel, let's start with you.
If I had to pick two, I would say AI optimization for surgery, like scheduling optimization, OR guidance, post-op recovery, even be used in post-acute to think about setting up a patient for home health visits, things like that. The other thing would be streamlining your partnerships, whether that's with an ASC or with your tech innovator, because in a lot of these instances, you can't go it alone.
In cancer, in the near term, is going to be focusing on effective triage and orchestration, oftentimes by tumor type, by risk level, demographic, and potentially even patient preference. In the range of conversations that we have with our cancer programs, it's often not being comprehensive. That's the challenge. It's about being connected. And that's often where the greatest challenge is. And being able to triage and orchestrate across sites of care will be important in the near term. In the long term, it's going to be leveraging partnerships to meet that demand. Cancer remains one of the service lines with some of the most partnerships across both communities and AMCs. Patients want communication and engagement after hours, and we see workforce being a limitation. So some systems are exploring partnerships to extend that care beyond hospital walls. So just one example of leveraging partnerships to meet that demand.
In a similar vein, draw that team-based care opportunity and drawing the circle bigger within the CV space. We can't operate in silos and manage our cardiovascular patients alone as cardiologists. We need to work across specialties more and more every day. Some of it is therapeutic driven, like the GLP-1s and cardiometabolic programs or cardio-renal metabolic programs. And some of it is a technology or a workforce play. Think about cardio-oncology and all of the opportunities that exist to work across specialties to better manage our patients. And then finally, Dionne, you've got a lot of similar stories as well.
In women's health, what's next is this urgency to rethink how we deliver care. One of the biggest barriers to growth is how narrowly we've traditionally defined women's health. It's been centered around OB and GYN. And while those are still foundational and core services and entry to the health system, it's no longer the full picture. And if we want to grow, we have to reframe women's health as a system-wide opportunity. Women engage with nearly every specialty. There's downstream impact across specialties, but also across the family as well. In our latest consumer survey, women continue to be the healthcare CEO of their family, especially in multi-generational households. So moving forward, what's next is redefining women's health as not just a service line, but as a strategic lever that can drive value across specialties and across generations.
Thank you to you all for joining me today and ultimately sharing what's causing the service lines that you cover, cardiovascular, women's health, cancer, and then surgery and post-acute care, to evolve and innovate and to really differentiate within healthcare. You all work incredibly hard to bring our listeners and all of our members the latest forecasts and the trends and all the news on a daily basis. So I appreciate all the time that you have spent with us today. I know we could have talked for a lot longer.
Definitely could have. And thank you, Setu, Dionne, Rachel, Chad, and of course, Kara. Thank you for guest hosting our episode for today. And thank you to our Sg2 Perspective listeners.
Thanks for listening. If you like this episode, please subscribe, rate, and review us, and or follow us on Twitter and LinkedIn at Sg2 Healthcare. And if you want to talk more about innovative healthcare strategies, you can always email me at sg2perspectives@sg2.com. Finally, Sg2 is a Vizient company, and there are a bunch of Vizient podcasts that you might like. You could find them at Vizient /podcasts. Have a great day.